Next presentation,
Thank you.
Dr. Narendra Singh Verma, who is going to be talking
Yes,
about
madam.
Toric marking topographer.
Yeah. Thank you, AIOS, for the opportunity. Yeah. This is my presentation.
Dr. Verma, shall we share the presentation?
No,
Yeah,
he's
yeah,
already
please.
put it. It's okay.
Yeah, shall I start?
You have put it.
Yeah,
You have-
yeah. It is
Okay,
about the
thank you so
dynamic topographer. Dynamic topographer. This is the first dynamic topographer, you can say.
I present to you an app for toric axis marking which has been integrated with Topographer. This device is an LED-based topographer coupled with the EasyTor app for easy and error-free toric lens axis alignment. Recall the face of the poorest and weakest man you have seen and ask yourself if this step that you contemplate is going to be of any use to him. Considering this thought of Mahatma Gandhi, can we make expensive technologies more accessible to poor patients? Prevalence of cataract in ages greater than 40 years is about 7.5%. One-third of them have an astigmatism of greater than 1 diopter. Presently, toric or toric multifocal lens implantation is the best option available, but the reliability of outcome depends mainly on perfect axis alignment. Misalignment of 10 degrees can cause a loss of 35% benefit provided by toric lens and usually requires surgical realignment by using basic operating microscope, immersion A-scan and manual keratometer. Surgeons are implanting monofocal lenses with minimal post-op refractive error since almost a decade. The majority of them cannot maintain expensive instruments, so they are reluctant in implanting multifocal toric lenses, as there are higher chances of unpredictable outcomes due to errors in axis alignment occur during measurement of axis and marking of axis, inability to measure angle kappa and angle alpha, inability to measure anterior and posterior corneal astigmatism and nature of astigmatism. Hence, there is a need for an all-in-one system which is easier, faster, patient and surgeon friendly, that is non-cumbersome to use, economical and also with an option to link with existing instruments, reliable with low maintenance. The common causes of errors in toric lens axis alignment are errors due to manual marking and errors during measurement due to head tilt. Manual marking is a contact method usually done by bubble marker or freehand marking. There are chances of error due to smudging or wipeout of mark. In this case, when the head is tilted from left to right, there is significant 27-degree error in axis measurement. In the right eye, the axis changes from 88 to 61 degrees, while in the left eye, the axis changes from 114 to 87 degrees. This system consists of 4 parts. Illuminating disc having 600 LEDs. Camera to capture high quality images in different light conditions. Processing unit provides multiple apps. Wireless display streaming capabilities to multiple devices. Topographer with the EasyTor app can measure axis and nature of astigmatism of anterior surface, angle alpha and angle kappa, prediction of posterior corneal curvature with respect to anterior, and finally assist in axis alignment of toric lens by marking axis of alignment on colored photograph. The basic steps are: during topography, capture a photograph of eye in the same head position. Calculate axis of alignment using Barrett's toric calculator. Use the EasyTor app to mark axis of alignment on colored photograph. Use the photograph intraoperatively for axis alignment. Measure K1 and K2 from manual keratometry. LED-based topography for measurement of axis of astigmatism. Simultaneously capture photographs for axis marking in same head position. Prediction of posterior corneal curvature with respect to anterior corneal curvature by comparing P1 and P2 Purkinje images. Measure IOL power by immersion A-scan. Demonstration of toric axis alignment. From menu, select toric axis marking. Enter patient data. The colored photograph of the patient will be displayed automatically. Enter 2 parameters, site of incision and axis of alignment calculated by Barrett's toric calculator. Increase the size of axis mark ring such that the dotted ring coincides with the limbus. The green light is automatically displayed, which denotes the final axis of alignment of toric lens. You can also display lens silhouette in the axis of alignment. There is also an option for marking 3 landmark points as yellow lines. The axis of these lines is displayed at one end. Save the picture. It can then be magnified and rotated as desired. Picture can be displayed on mobile, tablet or other display devices in the OT for axis alignment reference. Picture without lens image can also be saved and used as a reference to visualize iris structures. It eliminates parallax errors as the iris is very close to lens marks. You can also mark landmark points during the initial stages of surgery, which can be used for axis alignment or to double check the axis of alignment using degree gauge. Final check of axis alignment of toric lens. You can also compare lens marked with iris structures to eliminate parallax error, as the iris is very close to the lens marking. Pre-op and post-op pictures compare the axis alignment. Only 1 to 2 degrees of misalignment is present. Demonstration of apparent chord length mu, angle kappa and angle alpha. Select picture from the gallery and adjust size of the picture, move it in the center and freeze it. Now adjust optical axis white circle on the border of limbus, then adjust pink circle of pupil size on border of pupil. Then move chord mu icon in center of light reflex. Save the picture and increase the size as required. In the first case, patient is suitable for multifocal lens, but in the second case, he is not. In the first case, it is better to prefer extended depth of focus lens as optical axis, that is wide circle center is away from visual axis, so angle alpha is more than normal. These pictures are useful to easily explain the eye condition to the patient when they are unfit for multifocal lens.
Thank you. This is a dynamic topographer. This is the first dynamic topographer. If I am having, will give me some time, I can explain. It can provide 3D modeling of the cornea, and it can decrease the error of the keratometry because it takes the picture from 2 centimeter. I am telling dynamic मैं इसलिए कह रहा हूँ क्योंकि ये एक ही जगह से पिक्चर नहीं लेता है. टोपोग्राफर जो है 2 सेंटीमीटर आगे पीछे कंटिन्यूअस फोटोग्राफ लेता है, तो उसकी वजह से क्या होता है कि हम जो है 3D मॉडलिंग कर सकते हैं और P1 P2 की वजह से एंटीरियर और पोस्टीरियर सरफेस का 3D मॉडल बना सकते हैं. और उसकी वजह से केराटोमीटर जो रीडिंग है आईओ 700 वाले मास्टर वाले जो है वो टेलीसेंट्रिक लेंस यूज कर रहे हैं, और इसमें हम कंटिन्यूअस फोटो लेते हैं मल्टीपल्स, वी कैन टेक 1000 फोटो, और उसको जो है उसकी वजह से हम एरर को केराटोमेट्रिक एरर को नलीफाई कर सकते हैं. और जो 3D मॉडलिंग जो इसका जो हम अभी यूज कर रहे हैं उसमें कैसा होता है मैडम, जैसे समझिए कि एक कोई एलईडी है, जैसे ही हम जब आगे से फोटो लेते हैं 10 सेंटीमीटर फोटो ले रहे हैं, बाद में पीछे 12 सेंटीमीटर पीछे 2 सेंटीमीटर पीछे मूव करता है कैमरा, कंटिन्यूअस फोटो लेते हैं. जो सिस्टम जब पीछे मूव करेगा तो एलईडी की लाइट जो अंदर की तरफ शिफ्ट होगी क्योंकि ऑब्जेक्ट पीछे जा रही है, तो हर एलईडी जो है इक्वल रेशियो में मूव करनी चाहिए उसका ग्राफ, और किस पॉइंट पे फास्ट मूव करती है फिर स्लो मूव करती है, उसका मतलब वहाँ एलिवेशन फास्ट हो रहा है, तो केराटोकोनस अर्ली केराटोकोनस को हम इसमें डायग्नोस कर सकते हैं. P1 P2 जैसे P1 P2 जो है जब जैसे ही डायनेमिक है आगे से पीछे जब मूव करेगा तो दोनों की इमेज जो है इक्वली मूव करनी चाहिए. और P1 P2 कहीं अगर कहीं पोस्टीरियर कर्वेचर में डिप्रेशन है तो वहाँ P2 जो है ना उसके साथ नहीं मूव करेगा, तो दोनों में डिफरेंस आएगा, दोनों की कर्व में डिफरेंस आएगा. इस विल शो कि P2 जो है मतलब पोस्टीरियर कर्वेचर वहाँ पे डिप्रेशन है, एंटीरियर में नहीं है. हो सकता है कि एंटीरियर में डिप्रेशन ना दिखे एपिथेलियल की वजह से.
Thank you so much, Dr. Verma. I think this is a very elaborate this thing which will require, a presentation in greater detail. But it is a very good initiation start and a very good way of, doing it and doing it yourself. So thank you very much for your presentation. Partha, if you do not have questions, or Chitra, if you don't, then we can move on.
Comment, Dr. Narendra, very interesting.
Yes,
very interesting.
Said, we definitely need to see an elaboration of the whole.
Yeah.
Would really give the insights. Again, when you go on to the elaborate project profile, then I would also ask you to have a comparative study between what you have now and what your study gives us, or what your device actually gives us. So that's very, very pertinent to understand the strength and importance of your project.
Okay. Thank you, sir.
Thank you so much, Dr. Verma. We'll now